So it is time to begin. And first of all, I'm going to go a little bit slow here on the intro intentionally, so let people continue joining us. But my name is Fred Trotter, and I work for the CareSet Journal. And I'd like to start by thanking some folks. And the first people, of course, I'd like to thank are Amy Gleason and Kevin Duvall. Amy is with USDS, and Kevin is with HHS, and they'll be introducing themselves after I stop talking here. But I really appreciate you guys coming to this panel. Thank you very much. I'd also like to thank Academy Health, whose logo you can see all over the screen in various places. This is a Datapalooza webinar, and Datapalooza is coming up pretty quick now, and there will be more COVID data stuff. So if you're interested in this topic and you care about COVID data, you definitely need to be registered for Datapalooza and go to Datapalooza. There's going to be more stuff, and I think actually Amy and I have a panel on very specifically how the data flows from regional levels to the national level. So if you really want even more in-depth from me and her, you can get 2 doses if you want, which is now I realize is a pun in the area of COVID, 2 doses. Okay. I'd like to thank at CareSet Journal, Ashish Patel, Victoria Hernandez, and Brian Lang, many of whom are in the room here with me here. Thank you so much for helping to get this webinar off the ground. CareSet is a kind of two-sided company. We are a data vendor and we are a data journalism organization, and our data journalism would not be possible without being a data vendor. And we're the first company with commercial access to 100% Medicare claims. We sell to life sciences companies, and that means medical device companies, pharmaceutical companies, many of whom are in the audience right now. We would not be able to afford our data journalism unless without that, and we really appreciate it. So thank you so much. I'd also like to thank our data journalism partners. So we recently provided data to the Wall Street Journal for an article they wrote on fatalities related to COVID in skilled nursing facilities. So we focus only on the data. We don't really write articles or do anything else, and we rely on traditional journalism partners for that kind of work. And so I'd really like to thank them as well. And last but not least, I'd like to thank Coral Sword, who's providing me with this wonderful microphone, and we're going to be able to do some weatherman stuff where I can be in front of the data and some really cool things like that. And they're serving on the patio, and so if you are in Houston and you feel like having a cup of coffee, come join us at Coral Sword, and I'll buy you a cup of coffee after this whole webinar is over. So thank you very much. Next thing I'm going to talk about in general is why this is important. And the reason why this is important is that we all know that we're making huge decisions that impact thousands of people based on our understanding, our picture of the COVID pandemic. And we live in a society now, unfortunately, where trust is in question. It doesn't matter whether you're talking about ballots or COVID. There's a lot of people who question the veracity of what's being said by officials in these areas. And can we trust the data? It's a big question. And the answer cannot be, oh, you can trust us, right? That's not how trust is established. The way that trust is established is to be fully transparent and demonstrate the evidence behind the assertions that are being made. So if you look at the assertions that Dr. Fauci makes, for instance, about masks and social distancing and the isolation, after exposure, or even the need to run Thanksgiving over Zoom, any of these things, you can go to PubMed, and I think actually, Victoria, if you don't mind tweeting out that link to PubMed, you can go to PubMed and you can find the evidence that Dr. Fauci is referring to. You can check the math, and you can verify all those things that the CDC is saying. So that verification infrastructure already exists from the CDC to talk about evidence for the pandemic, evidence for masks, but what about evidence about the picture of the pandemic itself? How do we know that that's trustworthy? Well, in order to do that, you have to establish a whole framework of verification. You have to establish data sources and reconcile the data sources and make those data sources mature. And then you have to be able to demonstrate that those data sources are mature. And I think I'm going to go ahead and switch to a single slide here in that weatherman mode that I was suggesting. And Victoria, if you can make me give me the whole screen for a second. This is a picture over time of one of the data sets that Kevin and Amy work on, which is the hospital data. And you can see in general that in the part of last year, things were pretty dire. And it's hard for me to read this from here because my eyes aren't as good as they were. I know I can see it. It's not that I can't see it. It's that my eyes don't work. Thank you though. So the if you look at the blue line there, the blue line stands for the percent of hospitals reporting on an average day in a week. From my perspective, that's the line of reasonableness. Like once that line gets above 90%, which happened, I think, earlier than October last year, when it starts to get up toward that high end of the chart, you're talking about a data set where you can make really big decisions, the kind of decisions that needed to be made, that were made about COVID in a reliable manner. The red line, which is the new line, is essentially, from my perspective, as close to perfection as you're going to get. That is the percentage of hospitals reporting 100% of the data in a week. That means every single hospital reported every single day over the course of the week correctly. That is an incredibly high standard. And what you can see in the later part of this year and coming up to now is that they are essentially, on an ongoing basis, flirting with perfection, which is an incredible accomplishment. And it is, frankly, it's an incredible honor to be on a panelist with the people who are responsible for this success. And that's what we're discussing today. But there's a story behind this, and that story is what Kevin and Amy are going to be sharing. So with that, I think it's time to turn it over to Kevin and Amy with that question. Tell us the story. How do we get here? And then, yeah, make me a small person now. And when Amy and Kevin share their screens, make them big, please.
Hi, so I'm Amy Gleason. As Fred said, I'm with the U.S. Digital Service, and I've been deployed to the response since March of last year. It's been a long year. And so back in March, if you can remember, the whole pandemic was new and we didn't know a lot about it, and we didn't even really know what we needed to know. And, hospitals are a great example that we didn't know how many ventilators hospitals had or how many beds were available. And, the cases were coming in and, trying to understand if we had a complete picture of the cases and a complete picture of the deaths. So all this information, the testing data and percent positivity. And early on in that, Dr. Birx felt very strongly that we needed to have a unified set of data that the federal government worked with so that everybody wasn't creating their own data sets and their own analysis and their own metrics. And we also wanted something that we could share with the state and local partners so that we would all be looking at the same thing at the same time. So back at the end of March and early April, we stood up what's now called HHS Protect, which is where all that data sits. And I'll hand it over to Kevin to talk a little bit about HHS Protect.
Thanks, Amy, and good afternoon, everyone. My name is Kevin Duvall, and I'm the Acting Chief Data Officer of the Department of Health and Human Services. So, yeah, as Amy mentioned, HHS Protect is kind of this unified data platform for sharing data securely related to the COVID-19 response. So, we have over 200 data sets that are kind of brought together, a multi-tiered access model, and we share relevant data with our federal partners, with our state and local partners, to ensure that people have a common operating picture of cases and deaths, testing, mobility data, supply chains, all of these different facets that ensure that we have an understanding of what's going on, we have an understanding of how our hospitals are doing, we have an understanding of testing, and we have can build that into then actions and decisions at the federal level, at the state and local level, at the tribal and territorial level to support getting out of the pandemic. And so it wasn't something that was built overnight. And this is, of course, the same system that powers some of the public dashboards that we'll be showing in a little bit. I think Fred and or me will be showing those pieces, but that kind of gives you a sense of what Protect looks like. The screenshot on the right-hand side is actually from the system, which kind of shows, the different facets that are looked at. One of the more interesting ones is we track policy indicators at a state level. So if you remember back in March and April, there were the shutdown orders. There were, certain parts of society were closed due to local orders, generally from governors. And so we track those against kind of what happened with case counts and death counts to try to understand, which pieces and parts are kind of having an impact on slowing the spread. I'll turn it back to you, Amy.
Thank you. So one of the things that happened back in around May timeframe is we were realizing that the data coming into the federal government wasn't complete and it wasn't as timely as we would like. And at that time, the U.S. Digital Service is often asked to do what we call a discovery sprint, where we take a multidisciplinary team, and usually it's around 3 weeks, and we dive really deeply into some challenging area and come back with recommendations. And so the U.S. Digital Service went out in the world in May and June when no one else was leaving their house. And we traveled to health departments and hospitals and labs and testing centers and nursing homes and tried to really understand what was going on, what was working, what wasn't working, and how technology might be able to help. So these are some of the examples of things that we saw, just to put things into perspective of why gathering all this data is such a challenging thing. And some of this will be very familiar to everyone that's worked in healthcare technology, but there were way too many manual and paper processes. So the person on the left here, her entire job was to fax all of those reports all day long to different jurisdictions to make sure that they had the information that they needed. The person in the middle is a National Guardsman that is having to write the exact same information on the exact same form twice, so that one form could stay with the testing site and one form could go with the sample. And then on the right, this is a box of many, many boxes that were coming into the health departments of lab results. Many of them were like sticker receipt pieces of paper taped down with handwritten demographics at the top of them. Others of them were handwritten spreadsheet-like forms. So they have to take these in, try to read all of those and hand enter them into their surveillance system to be able to have them. Additionally, reporting was often required to multiple different places, and the volume that their systems were built for originally were just drastically higher for COVID. And then the other thing that we really saw a lot of is there were these non-traditional healthcare places that were standing up all of these different workflows. And while they were very creative, this is actually an example of one that's using paddles in English and Spanish on either side of the paddle to give instructions at a drive-up testing center. And they lined up lots of point-of-care testings with timers that they bought by each one and kind of created this really innovative workflow, but they had no real tools to be able to document all this information in to manage their workflow and to report it to public health. And so as we worked with the state and locals, we really were trying to help them figure out how to get the local health departments the information that they needed. And we stood up a bunch of things in the federal government to help those. And I'm not going to get into all of that detail, but I did want to highlight that fixing some of these challenges in the local side also impacts what the federal government has, because all the data that comes into the federal government comes from the state and locals or the facilities themselves. So you have to fix these challenges at the local area in order to have good, complete, accurate, timely data at the federal level. So as we worked on those and continue to improve, we stood up what we call the Data Strategy and Execution Work Group, which is an interagency group that's worked in the response. This group was actually created in June, and it brings in people from across all the different federal agencies and components of HHS. And we really work to unify all those data analysis and assets. So things like Kevin was talking about, hospital data, testing data, cases, mortality, vaccines, et cetera, into HHS Protect. And then we work as a team to figure out how we can make that data better, how we can measure the quality, how we can put processes around that to continually make that data better. Like you saw the example of the hospital data over time, that took a lot of incremental steps as teams to improve that data over time. And then once we have all that data, we prepare all these different analyses, things like the community profile report and hospital reports and models. Those things all are to inform federal, regional, state, and local and public action. So this is kind of the way our framework has gone. And that's really what's driven us to be able to have good quality data. And one thing to keep in mind is the federal government can't just put out data at any point because we want to share with the public, where somebody else might be able to just create a website and stand it up for use. But if it's going to come from the federal government, it has to actually be at a certain level of quality that we know what we're putting out. We understand the completeness, we understand the risk, and we understand the bias in the data, to make sure that we can caveat that, explain it, and make sure that it's clear and easy to be used by the public. So we had to go through quite a lot of processes just to get the data, to understand it, to improve the quality, and to make sure it was at that caliber to be able to release, which in the fall, we did feel like we got to that level on certain different data sets, which we're actually here to talk about today. And so we started releasing those at that time. Kevin, do you want to add to that?
No, I think absolutely. You know, Amy's team, who has just been fantastic, worked incredibly hard to ensure that what we are presenting to the American people is accurate and a mostly complete portrayal of what's going on. You know, you saw the trend line that Fred produced at the beginning, which kind of shows exactly the percentage of hospitals reporting. And so we make that data available to the public. It's in multiple forms and formats, one of which is the community profile report. We recently released the state profile report, which is kind of a one of the things that we saw was when people would search on our website, they wouldn't search, you know, COVID national picture, they would search a state name. And so through searching and kind of understanding that Amy and her team worked and released the state profile reports, which is really take out a given state and really get a good understanding of what's going on with related to COVID in that given state. And then in addition, we release data files, public use files on healthdata.gov that cover testing, estimated patient impact, actual patient impact, state and policy orders that are related to COVID-19, and a few other elements on there. So you can use those for analysis and review.
So, and now I think we're at a stage where we can talk about and give a little bit quick tour of two of the most exciting things. As Kevin just mentioned, there's actually dozens of data sets that are available on the various healthdata.gov websites or data.gov websites that are relevant. CDC has some, CMS has some, there's tons of them. But the thing that we're going to talk about here are the two reports that are, you know, kind of really almost, it's not even data, it's really data products that are used in order to inform decision makers who are on the ground making decisions at the national and local levels, but also now to inform the public. And so the first of these that was released is the community profile report. And I'm showing you behind me the first page of that report. And first of all, even here, you can just see that there's an incredible amount of information density. And these products are really well designed. There is up in the top left, you'll see the trend of new cases. And then you see the on the top right, lab positivity, that's above my head here. And then over this way, I'm trying to be a good weatherman here, that way, you see new deaths, right? And new deaths are essentially the delta, like how many people would have died newly because of COVID specifically. And some of this stuff, you know, right? And then immediately behind me is hospital admissions. And all of them are over the same time period. And so in all of the data, all of these sets, you can see the kind of summer surge and then the winter surge, and you can see where we are right now. I think critically, you also see in the hospitalization data behind me, for instance, that there's some missing data, and you see lab data is really complicated. I'm not going to get into it right now. It's so complicated. But I just think this is a good example of these pillar issues. If you want to understand the COVID pandemic, you need to pay attention to these big areas. And they are cases, deaths, hospitalization rates, and lab positivity rate. The next to come will be the immunization data. But to be perfectly honest, we need to get through that period where it's, you know, those pipelines are established and the reporting is controlled, and we're not there yet. So I think there will be a fifth column here eventually. But right now we have very good picture of what's happening on the first floor. Moving on, this is from the PDF version of the community profile report. We have the this is the percent change in case incidents, and I think what's really interesting about this is it's generally showing on the left it's bad, but on the right you can see, well, yeah, it's bad, but it is actually getting better, which is good news. And you can see that picture on a whole national basis. Again, that's the PDF version. You can also see trend lines that are, again, broken out by state. And in this one, there's case incidents. And by the way, I'm only going through a few pages of what is a 20 or 30 page report. There's a huge amount of information in these reports. Lastly, there's the Excel version of the report, which works a totally different way and allows you to drill down on a per county basis and understand what's going on. So here behind me, you can see Harris County, where we are, or at least we are broadcasting from, and you can see a picture. All I've done here, you can actually see across the top how I've arranged the Excel columns and kind of brought them together to give a picture of The cases last week, I believe, or no, I'm sorry, that's deaths, cases, and lab results, these same big categories. And you can see not just Houston, but you can also see other counties there too. So you can use this to get a picture of what your county is. This does not give you a picture of your state. And there's another product, which is the state product, which is a more recent thing, which is a series of PDFs. There's no Excel version of the state report, is there, Kevin? It's just the PDFs. Is that right? Just want to confirm.
That's correct. Yep, that's correct.
I feel very good about being right about that when I first started it. And in the same way that it's giving you a picture on a county level, on a community level for the community health report, this is giving you a state picture. Now, one of the reasons why I chose for this graph to be first is it actually kind of merges the kind of underlying issue about data quality here. So you see that line going across the top, that's percent reporting. And that matters, right? Because if that picture is not very high, if that's not nearly at the top of the chart for reporting percentage, well, it's hard to trust everything else in the graph. So they're telling you, here's the slowly improving, but mostly extremely good hospital reporting. And then underneath, we have these other categories of age-based hospital reporting here. And again, there's several more charts like this one that's in that report. Now we're going to look at, again, in the same way that we're looking at the whole country before, now we're just doing Texas. And again, there's one of these reports for every state in the country. And this is new cases and laboratory test positivity. And then again, you're seeing the same kind of thing, new cases and testing, but this is trend line over time. This is part of the state report for Texas. And you're seeing how Texas is different. And one of the things that I think if you're going to become a student of COVID data, that's really important to recognize, it is not hitting the whole country at the same time in the same way, right? It is not true to think that we have one COVID problem and it's all the same COVID problem. And the thing that's happening in your neighborhood is the same thing that's happening in every other neighborhood. There's very, very different things happening. The virus is spreading, as you would expect, organically. And so having these really focused pictures is really important. And now we're back at the beginning slide, so I'm going to go ahead and move back to the main screen. That's the quick tour. If you are interested in more specific information about the community health profile, CareSet has been tweeting out links to the frequently asked question pages that we've made about these data sets. And we have one for the community profile report. We don't have one for the state report. And actually, I'd like to understand from the audience if having one for the state report is helpful. And just in general, how many people have been using these. It'd be lovely to know that. And we've also made these videos in the same kind of weatherman style as we've been trying to do here. And I apologize, we're not CBS News here. Making videos is not what we do. But at the same time, these data sets are extremely complicated, especially the lab positivity rate, where it's really a subtle issue about whether or not you want that chart to go up or down or what the circumstances are. So so all of those things is stuff that we try to do a good job of explaining. And again, I think our role is to try to explain that and do better. We do have questions now. But before we get to the questions, Kevin, could you take a sort of quick tour of how you get to this data?
Yeah, sure. So let me share my screen. All right. All right, are you seeing my screen? Perfect. Okay. So right now, so there's two actually websites. They're both stubbed off of healthdata.gov, but I'll show you how to get to all the data. So there's beta.healthdata.gov, which is kind of our new portal. So right now we're kind of driving between the two. But you can see here, there's kind of two different sets of data. So this community profile report, which is a national level artifact. If you click on that, it will, and this is always fun. It's a good time test with streaming on Zoom as well as navigating the web. That's always a fun thing to do. It's even better when you're doing like live demos of things. So you can see here, this is where you get the community profile report. It's got a nice, the previews of the PDF, and you can scroll through it. If you want to download that artifact and print it out or kind of whatever you want to do with it, distribute it among colleagues, you can download it right here. And then down here is a listing of every single one we've posted since we began posting it. So you can kind of click back through and look at how things have changed over the past, I guess it's been almost 3 months. This button, so this contact data set owner actually goes to us. And so questions can be pointed there. And so you can see at the very bottom, the latest one. In general, they are posted either, so for a given day, so the 11th, it will be either posted in the evening or the morning after the given day. And these are published daily. So that's one viewpoint, and this is, again, that national view. Since we're in the spirit of showing Texas, we'll search Texas on beta.healthdata.gov, and then you can drill down. This profile report, the state one, is published weekly. And so that's published either Monday night or Tuesday morning for a given state. And again, we've been publishing it for 3 weeks. And so you can see kind of what's going on here, and then flip through a very state-centric view, including the District of Columbia and Puerto Rico. For the people that want to do their own analyses, I would head over to healthdata.gov, and as I keep telling people, click the big red button. And so this actually lists all of the data sets that you can pull down either CSV or Excel files from. And so we do estimation for patient impact and hospital capacities. We gather as is state and county policy orders. We publish our PCR testing time series. These are state aggregate views, both a file that covers a given snapshot of the day, and then a time series file. Fred kind of covered earlier the facility level file, which is I think kind of HHS first. So you can drill down and see a facility level view of data, and it's summarized per week. And then coverage reports, so that's how well hospitals are reporting. And then this community profile report actually links right back over here.
So I know that there's people who are asking for us to go back to the slides and show a slide, and we can't do that, but because there's just so much. There's thousands of slides. Like we just showed you 5 or 6 slides of the universe that Kevin just reviewed, which has, again, thousands and thousands of websites. So so I'm very sorry to the person who's asking to go back, but we can't. Carry on, Kevin.
What I don't want to show
Amy's
a lot.
Going to also show, the CDC side.
I just wanted to show, this is also the CDC data, COVID data tracker also has things. So like if you go to the healthcare systems here, you can look at trends in ED visits and things like that. You can also go to your community and look at a county view of information. And so like if you wanted to look at different things, so hospital utilization, then you can also, it's got a little bit of a delay, sorry. And then you can also pick your state. So if we wanted to go to Texas or whatever state we're looking at here, then you can also pick a county. I'm just going to pick one at random so we can see that. But then you can also see how it compares to other states and different stats around that county. Sorry, I'm running into the same lag that Kevin did.
Well, so as we wait for your lag to resolve, I think it's just really important that I think there's almost 2 streams coming out. One is the kind of raw data, which is literally you download something and you get a massive CSV file or something else. And then the other is these kind of higher level analytics products, the ability to browse, see charts online. And we're really trying to hit all of the audience in terms of, kind of sophistication of working with data. But if you're going to look at the raw data and you want to ask questions that haven't been asked yet, you really need to take a look at the raw data. And, it is complicated to work with. You sometimes have to work with CCN data from CMS in order to understand the keys for looking at the hospital data. So you do have to do a little bit of work to get full pictures on stuff. And so again, we are trying to create a little bit of a community on those of us who are the outside data journalists and researchers who are working with the data to try to have a little bit of understanding to accelerate our understanding of what's coming out at the very low level. But I'll have to say, these data products that are coming out, these browsers and the Excel products and the PDFs, they're really good. And I think one of the really important things to note is that those PDF and Excel products and those websites, they're the same ones that governors and presidents, we only have one, I guess we've had 2 relevant ones. We have presidents are making decisions based on these products. Like this is the picture that we are using to make decisions as a country at all levels of government. And so You can also see the difference between how the raw data that's being released is kind of merged into these data pictures. Again, it's in some senses the transparency here. The only problem with it is that it's the deluge of data that has to be managed and understood. Anything else you wanted to say? Amy, you got the picture you wanted to keep going?
Yeah, I just wanted to show. So this is actually at a county level. So if you're trying to make decisions for you and your local area, you can look at the case trends and see what's happening, deaths, positive percentage, the testing volume, as well as hospital admissions, percent of beds used, and the percent of ICU beds used. So this is really helpful data when you're looking at your local area and trying to understand. And there's a lot of other data here also on the COVID data tracker. So this is a great resource. It also has a lot of vaccine data already.
Something I feel like I should, because this is going to be recorded, people are going to watch it possibly over and over again, and who knows what news source is going to get this or what conspiracy people are going to refer to this. Let me be clear: nothing that we're showing and no data that we're interpreting should be interpreted as, oh, now that I can see the data about what's happening in my backyard, I can ignore the CDC recommendations. Like, that's not the takeaway here, right? The CDC is always going to use best practices and good science to look at all this data and make recommendations about whether or not you have to be wearing masks. And as long as they're saying you have to be wearing masks and doing social distancing, you should be wearing masks and doing social distancing. I think that's something that my government employee co-panelist here can kind of emphatically nod with, but that's just something, because of how the internet works, I think I have to say that.
And somebody asked in one of the questions about the differences between the data for these different products. And I wanted to mention that all of these use the same data set. So that's the whole idea of having this unified data set in HHS Protect. So the CDC COVID data tracker is using the same exact data that the community profile report is using, that the state report is using, and the hospital reports are using. Now, if the CDC site, they might add extra things to it that are not in those other things, like they have like social vulnerability index and things like that are maybe not in some of the other products. They might add things, but the data sources are the exact same.
One of the other important questions that I see here is there racial data and race data included in this information? The answer is yes. There are columns, especially in the Excel version of the community health profile report, that is one of the ones that we're talking about here, that does include that information. And the stories that you're seeing about racial disparities are being powered by the data sets that we're talking about. So yes, absolutely, there is that data there, and it is precisely there to make those analyses possible. And I guess, you guys can, if you guys see questions you want to answer, please just jump in. There's a lot of questions coming in, and that's the time. This is the time for questions.
I guess, so Justin wrote in about lags in reporting. So yeah, Justin, good point. So there are, the overall schema of this is, we receive data from states. State health departments are generally collecting this information both to report to us as well as to do contact tracing. And so that data then flows to the Centers for Disease Control and Prevention, and then flows into HHS Protect. Sometimes, there's things that happen in that reporting chain. So if, as Amy showed before, if people are keying in data and for whatever reason, there's a piece in part that gets behind, there will be leads and lags, as well as, there's independent jurisdictions that are all kind of reporting into a common place. Pipelines every once in a while have a lag in them. And so, yes, you will see from time to time that a certain state will be more delayed or will have reporting and then stop, and that's kind of to be expected as part of the data.
When reporting lags do impact how often we can release data and how often we can do things. So, there are some places that only report lab data weekly instead of multiple times a week. And so if you're going to do 7-day averages and show that, obviously when you only get one big dump on a one day of the week, that makes it more challenging. So there are some different situations like that we deal with, but on the most part, we have a pretty good consistent data flow at this point. It's just, it might take a few days for it to fill in. Like the lab data, we usually show like a 4-day back gap, for example.
Correct me if I'm wrong, but the lag shows that the lag on every data set is unique to that data set. Every data stream has its own lag phenomenon. I don't know if you guys remember from that first slide that I was showing about the time periods, but you can see weekly reporting patterns that are essentially lagged. So some things are not reported on the weekend, which causes a day of the week effect inside the data. Understanding the lag for these data sets is really critical. But and the place you go to understand the lag is in every one of these data files, there is a kind of, here's what we got the data caveats. There's usually on the last page of the report, there's a bunch of kind of notes, methodology notes, and you can find out about the lag and all those information from those methodology notes. And it's really important that the lag in general is something that if you're going to do serious analysis of this, you really need to understand. There was a question about social determinants of health. That's actually one of the reasons why understanding how this data keys back to other things is really important. So many of the data sets about hospitals are keyed to the CCN database, which is a Medicare issued number from CMS. And that ties back to zip codes. In fact, there is a whole data set called the Dartmouth Atlas, the Dartmouth Health Atlas, which is essentially the relationship between the locations of hospitals and the regions that they cover, that allow you to use census data to look at social determinants of health and to merge these data sets. But you do have to do data work in order to get to social determinants of health. They are harder because in many cases, they are not necessarily reported in the stream. You have to do data linking in order to get to those. So I think that's the answer to that question. And I'll leave it to Amy or Kevin if you see one you want to answer.
There's one question about data governance, which I thought might be interesting one to talk about. So kind of the whole idea of the data strategy and execution work group is to provide every day, all day data governance. So all the different agencies send their representatives in. So like there's a group of people that come from the different agencies on case data and on lab data and on mortality data, hospital data, et cetera. And so those people are there, representing their agency views, and then they have reached back into all the subject matter experts in their agency. So as we make decisions and as we grow the data and improve the quality, it truly is this group of subject matter experts across agencies working on that together and working on improving those and measuring it and growing it together. So that's the way the governance works for the most part.
Yeah, and I just add to that, where we plug in, we're the Office of the Chief Information Officer and Chief Data Officer. So we kind of are the technical underpinning arm that supports that interagency activity. And so we work, of course, very closely with Amy to, implement those decisions and make decisions together about how we protect data and use data effectively to, again, drive these data products. And included in that interagency body is, of course, the Centers for Disease Control. They're our partner in all of the development of these products and have been, we've all been kind of in this from the beginning, making sure good things are happening with the COVID-19 data.
Yes, they're a huge part of our interagency team. Let's see.
So one of the questions I'm seeing is there a breakdown of racial data? How about gender or sexual orientation? I'd say that there probably is a little bit of gender data that's inside HHS Protect, but I can say that in general, sexual orientation is not something that's typically surfaced all the way up into HHS Protect. And so again, you can do regional linking analysis to make estimations about that. And again, I hate to be frank, but I believe that in general, the health reporting infrastructure writ large is far more mature on race, although there are problems with the way race is reported too, that kind of make that difficult to interpret in some cases. But we're not where we need to be on those topics, and I don't think that should be something that should be regarded as criticism for Amy and Kevin's work. I think that's a criticism of the healthcare technology industry in general, is that we don't do a great job of surfacing that in the ways we need to.
Yeah, and I would say there was one question about how granular the level of data is. So the hospital data, which I think this is asking about, specifically is reported daily by the hospitals, except for the supply data that's reported once a week. And then the rehab and psych hospitals only have to report once a week, but everybody else reports daily for most of the data. We publish that out as a weekly data at the facility level, where we do a sum of all the values for the week, as well as an average based on the number of days that they reported. So if they only reported 5 days for a value, that you would divide it by 5, so you get a true daily value. We do that at the weekly level, mostly for privacy reasons. So, if you're in a small town and it's the only hospital and there's only one person in the hospital with COVID, you might know somebody's in the hospital and you're sharing that information. Also, the hospitals, from what we learned through the hospital associations, are used to having data published like this at a weekly basis. So we're trying to, continue to build their trust in reporting the data and reporting it in a way that they're comfortable with as well.
So,
and I saw a few. Oh, go ahead.
So sorry to interrupt, Kevin. If you guys would pick one question, your favorite question that you can see each, and then I'd like to talk about the last question I'd like to ask is about kind of the impacts. But we're almost out of time, and I think one more question each is good.
So I saw one on timing. So it's important to kind of fully contextualize that the data that was collected has changed over time. So towards the March-April timeframe, there was an initial collection of data, and then in July, a kind of more expanded collection occurred. And so people are asking, like, is there data beforehand? For the most part, related to the COVID data sets, March-April timeframe is really the start of it. And then that July timeframe is where you're going to see this consistent, more expanded data set about hospitalization occurring. And that's hence what is available for the facility level file for hospitalization. So, this has evolved over time, and, Amy's team has worked to really try to balance. One of the other things that we have to consider is, what's the burden on the healthcare system when we're collecting this information. And so lots of late evening calls between Amy and myself trying to figure out, should we be collecting this, or can we collect it in a slightly different way to ensure that at the end of the day, we're balancing that appropriately while still, giving visibility into the challenge.
Yes, I actually saw 2 questions, so I'm going to cheat. So one is about the difference between state reported data on their websites and the data that we publish. So the hospital data, there's actually been some external validation showing how close they are, except that a lot of the times our hospital data at the federal level is 1 day ahead of some of the data that's published on some other sites. And sometimes the state data is the same, but those are lined up pretty closely. Where they're not lined up is usually definitional differences. So for example, if we're publishing confirmed only admissions and the state is publishing confirmed and suspected admissions, which actually we post both, but if you're looking at different definitional things, it may not say on their website how they defined an admission. We know, like, an example, one state at one point was using only people in the hospital at the time their case was reported. This is what they were putting on their state website, where we're getting it straight from the hospitals, how many were admitted the day before. So most of the time when they differ, it's more of that. On the same with lab data, states might publish it based on the symptom date of cases, for example, or the collection date of labs, where sometimes we may only have the report date of the case or the report date of the lab. So there can be differences like that, but they should be getting closer and closer together as time goes on. And then the other question that I saw that I thought really relevant is, was there anything that happened during all of this that's long going that will be helpful in the future after COVID? And I think this has definitely created the ability to look at things that we haven't had before, especially with this unified system. And the hospital data is just one example of many, but there are always some kind of emergency happening in the US, whether it's wildfires or hurricanes or tornadoes or the flu season or whatever is happening. And we haven't ever really had this ability to see inside of what's happening like this before. And so we're hopeful that some of these systems will stay around and be maintained and be able, maybe not reporting to the degree that we're doing now and the frequency and the detail, but the systems will be maintained and be available in case there were needs like that to increase the data frequency or depth of data in the future. So I definitely think there's things to take forward from this.
So thank you for your answers, and appreciate you taking two there. That's that's wonderful, Amy. So listen, you know, I am surprised by the deluge of questions that we're getting. We prepared questions to ask if we did not have ones ready. I want to encourage you, even now, if you want to ask a question, go ahead. And we will take the questions and we will either put them in the answers in the FAQ or we'll find some other way to do it. Amy, do you have a question?
I have one more I saw. Can I answer it, please?
Yes.
Okay, and I'll stop after this. So somebody asked, can you give a good example of how we've used this data to drive action?
Well, that's actually the
had...
final question and where we want to end. So Amy, can you tell us what have been the impacts of this data? You know, if you're a health technology professional, the kind of warm feeling you get to have when you go to sleep is knowing that data pipelines is dry work. And again, I want to emphasize that the systems that Amy and Kevin are working on, there are tens of thousands of people who labor extensively and will never see the impacts of the fact that their hospital reporting turned into something that allowed decisions to be made that they'll never see. So in some senses, you know, for those tens of thousands of people who've contributed to this data, Amy, what are some stories that you can tell us about how the use of the data has been used to really help?
Right. So one example I wanted to share is we stood up a project called Project Greenlight in the October-ish timeframe, and it takes data that's submitted into HHS Protect and a lot of it the hospital and long-term care facility data, and does alerting on that, where we will then outreach to states and or facilities to validate that information, but also to get contextual awareness. So you're at 99% ICU capacity and your cases have risen over the last week. We think you might be running out of space. Do you already have a plan? Are you able to do something with that? And in some cases, we've alerted states that we thought a hospital was in trouble ahead of time, and they actually prepared for an alternate care site that went live the day they needed it, because we were driving some of that early intervention where the federal teams were able to support the state teams with an alternate care site. Another example is on supplies. So when hospitals report that they're having trouble getting supplies, we can validate those things. And, usually they're handled at the state and local level, but at sometimes when the states can't resolve those, they will ask for federal assistance from the Strategic National Stockpile. So we're gathering all that contextual awareness of how that's happening over time and preparing the supply team. Hey, we think there might be an issue coming up with gloves in some state, and they can be preparing for that. And we have all the data already validated. So if the state says, hey, we need gloves, then they already have it validated and can fulfill that request a whole lot faster. And the same with staffing. So there are limited staffing resources that the federal government has to offer, but we do offer some when needed. And so when we can validate those staffing needs and what types of roles there are and what the trends are, and prepare that team so they know to be looking for staff and preparing in case it's needed. And again, to shrink that time to get that data down. So those are 3 big examples of ways that we are using this data every day to drive the federal response.
So Amy, Kevin, thank you so much. I think that's a great place to end the webinar. We are at time. Again, if you have questions, we're going to leave the things up for just a few more seconds so you can type in that last question, and we will try to run it down and get some kind of answer. Some of these questions are, as you might expect, totally inappropriate. We may not choose to answer those, and some of them are a higher level or a lower level, but in some way or another, we're going to do something with all these questions. So I really appreciate the audience members. Thank you guys for coming and showing up. And again, Kevin and Amy, thank you guys so much. I really appreciate you doing this.
Thank you so much for having me.
Yep. And I just want to say, to end on Amy's point, thank you to all the healthcare workers that make all this data possible, as well as, everything you do every day to fight the pandemic.
All right, I'm going to press a little button here that's going to go back to the title screen. Everything's going to be over. Thank you guys so much. Bye-bye.